request Dr. Waqar Hassan to kindly share his screen and start with the presentation. So we have 13 participants up till now. I will request the participants to kindly post their questions in the chat box. I will keep a track of your questions, and we can also, if we have time, we can also give you opportunity to ask directly. So we will start. Dr. Waqar, you have to unmute yourself.
Bismillahirrahmanirrahim. Can you see my share screen?
Yes, thank you.
Okay. Okay. First of all, I will thank to Dr. Aisha and Dr. Faiz Ali Shah for arranging such a good activity in this scenario of pandemic corona, and because we cannot live without learning, and so this is another technology which we are using now, and the students should have get a good enough advantage of it, because we have an expert of Dr. Fayaz Saab from the KTH, who will comment on the this article in the last. So I'm thankful to all of the team for arranging such a good activities. So I will start from this my article, which has been published in the last journal, and the other co-authors I will thank Dr. Mahmood Al Hassan, Dr. Shamsur Rahman, Dr. Naeemullah Khan, and Dr. Wali Muhammad, and Dr. Sayyid Imran Bukhari for helping me in this research article. Let's start with the introduction. The pedicle screws and rods fixation is a modern technique of internal fixation in the traumatic, degenerative, and deformity of the spine. Actually, the aim is for obtaining a rigid fixation, biological union, and minimizing the complication of pseudoarthrosis. There are various techniques of pedicle screw insertion, but focusing on the safe insertion to avoid iatrogenic injury to the spinal cord or nerve root is of paramount importance. There are various techniques: the freehand technique, fluoroscopic guided, CT guided technique, and computer assisted navigation system, and computer assisted robotic technique. Among these, the CT guided has a high accuracy rate. However, it has a hazard of radiation exposure. And among that, the computer assisted also has a high accuracy rate. But you know that this technique is technically demanding, more time consuming, and expensive, hence not feasible to use in the developing countries. There are variations in all technique of using anatomical landmark, so you will see a difference in the accuracy rate results. Otherwise, the freehand technique is a safe, accurate, and reliable method of pedicle screw insertion for fixation of the trauma, degenerative spine disease, and deformity of the spine. Okay, in one of the systematic review, it has mentioned that the surgical time which is taken by image guided technique is 257.7 minutes, while the freehand technique get 226.8 minutes. It's a difference. But the complication is 1.6% in the image guided and the freehand technique in 1.7. So it is not a significantly different. Due to the lack of advanced navigation system, we use the freehand technique using a universal entry point and a fluoroscopic control. Okay, the objective of our study was to determine the safety of the pedicle screw fixation of the spine by freehand technique in terms of screw malposition and screw-related post-operative neurological, visceral, or vascular injuries. This study is a descriptive study and conducted in orthopedic department of Lady Reading Hospital, Peshawar. The duration was from 23rd April 2017 to 23rd March 2020. The inclusion criteria was the patient of either gender and age operated with pedicle screw fixation of spine by freehand technique using universal entry points were included, and the post-operative radiograph of the spine were utilized for the screw position. In the included subject, complete history, physical examination, and AP and lateral radiograph of the spine and MRI were done. In a patient with malposition, radiographic screws and with the screws related to the post-operative complications were screened with CT scan of the spine. So the technique which used in the cervical, thoracic, and lumbosacral were the freehand technique, which is explained by the Zhang, So in this picture, you can see that the technique is very simple. What if you concentrate on this slide, that the first picture is for the cervical spine, second is thoracic and lumbar. The common thing is that you have to identify the lateral border of the superior articular facet. This is the superior articular facet of the lower vertebra. This is the lateral border. And in this thoracic, this is the lateral border, and similarly in the lumbar, this is the lateral border. And the second point is that in the cervical spine, you will identify the lateral mass. This is a lateral mass. So the junction of these two landmarks, this is the point here where they are meet. And the thoracic spine, similarly, the upper border of the transverse process and the lateral border of the superior articular facet, they meet here. And similarly in the lumbar spine. So the point is that the entry point for the pedicle was 1 millimeter caudal and medial to this junction. This is the junction point. So 1 millimeter medial and caudal to this junction point. Similarly in thoracic, about 2 millimeter medial and junction caudal to the this junction of the superior articular facet and the transverse process. Similarly, for the lumbar, they have mentioned 3 millimeter medial and caudal to this junctional point. So this is the common entry point for making the pedicle screw track. And the axial and sagittal trajectory were perpendicular to axial and sagittal plane of the lamina of the isthmus. So you have to identify the lamina in each of the vertebra. So you have to be perpendicular in both view, in axial and sagittal plane. So that will be your trajectory of pedicle screw. In this universal entry point is located at about 1 o'clock and 11 o'clock on the axial view of the pedicle. The cortical bone of the entry point was breached with all. So when you identify the entry point, you have to make a breach in the cortical bone by all. Okay, next, then the pedicle was cannulated to an appropriate depth with the help of a blunt gear shift, keeping in mind the axial and sagittal trajectory. Feeler with a ball and a tip was inserted to confirm any pedicular breach. Appropriate size pedicle screw was inserted after probing and taping. Okay, then post-operative, we collected the data and assessed the clinically for neurological, vascular, or visceral complication, and AP and lateral radiograph were ordered. The radiographic assessment of the screws placement was performed by 2 senior orthopedic surgeons who were not a part of the study team. The patient with malposition radiographic screws and those with the screws related post-operative complications were screened with CT scan of the spine for confirmation of the screw malposition. So this is the CT based position pedicle screw, which is classification given by the Zhang, in which the first one is type 0, meaning that the screw inside the medullary canal of the pedicle. So there is no breach in the cortex. In type 1, there is less than 2 millimeter perforation of the pedicle cortex. This 2 millimeter means that the 2 millimeter of the screw die is inside the canal, or it is outside the cortex. Because the screw malposition can be toward the medial side and toward the lateral side. And the second type 2 is the breach is 2 to 4 millimeter perforation, while the type 3 is more than 4 millimeter, or if half of the diameter of the screw outside the cortex. So you can also, without, if you have no measurement system in the CT scan, although it is available, but if you use the 6 millimeter screw and half of the screw is inside the canal, so it means that it is perforated about 3 millimeters. Okay, if you concentrate on this slide, the first one, you can see that the screws are accurately inside the canal. There is no breach. Then on the B, if you can see that this screw is a little bit medial, and on zooming and calculating, it was found that it was 1.9 millimeter breach in the cortex. This is less than 2 millimeter. Then in type C, it is also inside the canal, and when zooming and calculated, it is 2.5 millimeter. Although it is more than 2 millimeter, but less than 4 millimeter. In this case, the slide D, you can see that it is not inside the canal, but outside the cortex. So it was measured and it was 5.7 millimeter breach in the cortex. And the last one, which is more than 6 millimeter, it appears that the screw is totally outside the cortex or pedicle tract. Okay. Symptomatic pedicle screws and the type 2 and type 3 pedicle screws were revised and patients were regularly followed in OPD for 1 year. A comparison of screws that were inside the pedicle with those that had breached the pedicle were done and p-value calculated with chi-square test. P-value of less than 0.05 was considered significant. Our results. So the total number of patients in our results were 96. The mean age of the patient were 34.20 years. Female were 53% and male were 46%, 46.9. So the most of the cases were from the trauma. 43 cases were from the trauma and 27 from the degenerative spine disease and 26 cases were of deformity. Okay, then the result, you can see that the total number of screws which we analyzed was 717 screws. Among that, 59% mean 425 screws were in the lumbar spine and 250 screws, 35% in thoracic spine and 42 screws in sacral spine. But no screws were from the cervical because we haven't passed the pedicle screw in the cervical, where rare cases which come across. So we haven't got most of the data of the cervical screws. We use the lateral mass screws mostly in the cervical spine. Okay, then the position of transpedicle screws, we see that the correct position was 96%. 684 were inside the pedicle, while 4% that were 32 screws were outside, or it was breaching the screw, the cortex of the pedicle. Now in this malposition screws, you can see that on this side that the thoracic screws were 21 while lumbar were 11. The thoracic screws are more than lumbar. Although we have used most of the screws in the lumbar spine, which were 59% and 35% thoracic, but the malposition incidence is more in the thoracic spine. So in this CT scan classified the 4% of malposition screw as a type 1, but the patients were asymptomatic, while only 3 screws in the 2 patients were symptomatic, type 2, and revision was done. No screw-related vascular or visceral complication was reported. In our case, this is one of my case that I operated 45-year patient with L3-4 spondylolisthesis, operated with transpedicular screw fixation and decompression. And the post-operative patient had radiculopathy on the right side on next first post-op day. So we proceeded with CT scan for the screw position assessment. Because if you see the X-ray, this is the X-ray of the lumbar spine, which L3-4 spondylolisthesis, and after surgery, this is the lateral view. You can see that the screws are seem to be in the pedicle on the lateral view, but on the AP view, it is not sure that on the right side are the screws in accurate position or it is breaching any cortex. So we assessed it with the CT scan, and this was the result of the CT scan. And if you concentrate here, that on the right side, the screws were breaching the our pedicle. So if this is, we have used this 6 millimeter screw and half of the screw is inside. So it means that the 3 millimeter perforation has been done here in both of cases. And luckily, we revised the case on the next day, and the perforation was confirmed with all. And we revised the screws with a change of our trajectory. And after the second surgery, revision surgery, patient was recovered with that radiculopathy. So in our discussion of this article, we have seen that our results were 4.6 malposition rate in our study, 4.6 cases. So these are the various results of the malposition by freehand technique over 2004 to 2020. This is our last our study, which is 4.6% of malposition screw. And among these studies, you can see that a Fisher had 33.8% highest rate, and there are variable results shown in this slide. So we will discuss some few points in this malposition literature. Hojo and Ito demonstrated a higher malposition rate in a patient with rheumatoid arthritis, 26.8%. And then in the spondylotic, 16.6%, and then traumatic spine, 11%. So these are the author advocated the use of image guided for accurate placement of pedicle screws in case of rheumatoid arthritis and spondylotic pathology of the cervical spine. Okay, in the deformity correction of the spine, you know that the superior articular process and transverse process are usually abnormal in size and distorted in shape due to deformity. And Rajan, in his series of 100 screws, noted a cortical breach in 12% in freehand technique and 10% in freehand supplemented with intraoperative fluoroscopy, although it is not statistically significant, 12% and 10%. But the average number of fluoroscopic shot for passing each screw was 7 minutes. This is important that one screw takes 7 minutes, and each screw inserted with freehand technique without fluoroscopy consumed 2 minutes less than inserted under C-arm. So it means 5 minutes. This is statistically significant result that it takes less time compared to the using any fluoroscopic guided or CT scan guided. So what is the problem in thoracic screws? Why our results are more malposition in thoracic spine? In our study, majority were 66.6% of screws were malposition, while followed by lumbar in were 33.3%. In upper and middle thoracic vertebra is the challenging because of many factors. Number one, smaller size of the thoracic pedicle, smaller diameter of spinal canal, and variation in pedicle axis and angle of pedicle body, and fear of fracture of pedicle, and adherence of thoracic viscera to the anterior longitudinal ligament. So there are these are the factors which should be keep in mind, and most of the time we have very narrow point to escape from the malposition. Now then, a study has been demonstrated that no neurovascular complication occurred when pedicle screw perforation was less than 2 millimeter. These are various studies have shown that if it is 2 millimeter or less than 2 millimeter perforation, and there is very little chance of neurovascular complication. Neurological complication due to malposition screw were only manifested when more than 4 millimeter of medial pedicle wall has been perforated. Now you concentrate on this slide, and this is actually a summary to remember that Kim has proposed that if there are no abnormal electrophysiological changes signal, then the medial cortex breach within 2 millimeter, it is a definitive safe zone. If it is 2 to 4 millimeter, that is probably a safe zone, while more than 4 millimeter is questionable. And another author, Garbage, believed that medial breach within 4 millimeter is a safe zone, while beyond 4 millimeter is a dangerous zone. So both are almost alike. So we have to keep in mind that if it is more than less than 4 millimeter and there is no electrophysiological change signal, so it is a definite a safe zone. And if it is more than 4 millimeter, then it is dangerous. We have to revise. So the conclusion of our study is the freehand technique of pedicle screw fixation using a universal entry point is a safe and reliable method in the absence of advanced navigation system. A thorough knowledge of the spine, anatomy of the vertebra, and surgeon experience are, however, mandatory for safe placement of the pedicle screw with freehand techniques. A given technique like intraoperative fluoroscopy, navigation, and neurophysiological study, when and available, must be used to enhance the accuracy of the pedicle screw and to avoid complications. So this was all about my article. And over to Dr. Aisha and Dr. Ayaz for further comments.
Yeah, thank you very much, Dr. Vakar. This was a very elaborate and nicely done presentation. And we understood most of the parts of your paper, especially how you referred back to the existing literature. So before we move on to questions, I'll request to Professor Mahmood Ayaz Saab. He's currently serving in Khyber Teaching Hospital, Peshawar, KPK, for his remarks and expert opinion on this particular topic. So
Okay.
welcome, Professor Saab.
Okay, thank you very much, Vakar, for a nice presentations and presenting your article in a very nice way. I am also thankful to Dr. Faiz Ali Shah and Dr. Aisha for inviting me to this journal club meeting. The presentation was all right, and he has presented his article very nicely. But first of all, I will pose this question, and I will ask this question: as this presentation was according to the already floated format, or it was just a presentation of the article? Because the sixth question which you have floated for any journal club presentations, the format was not exactly followed. This is one question, and Aisha and Fayaz will answer to this question. As far as the technique of the freehand technique is concerned, this freehand technique for a pedicle screw fixation is practiced by many spine surgeons, and it is considered a safe and effective technique for pedicle screw fixations. And as Wakar mentioned, if you see, it is a very good recipe for the lumbar, thoracic, and sacral spine. Although the technique is a bit different and technically demanding for the cervical spine. And this freehand technique has got a global acceptance as well, as because majority of the spine surgeon use this technique. And you can add other technology to your technique only if you are master in the freehand technique of the lumbar and thoracic spine. Although this freehand technique has enjoyed a wide acceptance for the lumbar spine, but it is a bit challenging in the thoracic spine because of the critical neurovascular anatomy. As Vakar already mentioned, the different points that why it is difficult in the thoracic spine if you compare it with the lumbar spine, and even more difficult and challenging and demanding in the cervical spine if you compare then with the thoracic and the lumbar spine because of the critical posterior, that is the neurovascular structure, nerve root, cords, and vertebral artery anatomy. As Vakar already mentioned, this technique, this freehand technique must be mastered before if you are using any aids to it. And the modern surgeon enjoy the different type of adjuvant technology like CT guide, intraoperative C-arm fluoroscopy, intraoperative computed tomography, computed assisted navigations, and even nowadays robotic surgery has been in practice. Although these different type of new technology has gained a lot of popularity, but they are associated with a certain limitation also. And the most common limitation and of these different technology is exposure to the radiations. And if you compare it with the exposure to, you see with the freehand method, the surgeon as well as the patient are relatively safe as compared when you are using fluoroscopy or you are using other navigation system for the second important limitation of these different technology. As you see, these navigation, these different type of technology are cost effective. And of course, it increase the operative time, as Vakar already mentioned that if you are using the freehand technique and if you are using just a fluoroscopy, it increase the operative time by 2 minutes for a freehand method as compared to fluoroscopy. Therefore, it has been recommended, and it is a very paramount importance that in developing country, the freehand technique must be practiced and must be mastered at the same time, because we don't have the resources of, for example, of intraoperative computed navigation system and other important thing for us. Therefore, these freehand technique are important. For this freehand technique, two important thing must be. One must be familiar with the local anatomy of the spine, and must be familiar with the anatomical landmarks. And second, the entry point should be properly identified, and entry should be made in a very proper and accurate places. And then the trajectory should be followed with a blunt instrument. These different type of points for the cervical, for the thoracic, and for the lumbar spine has already mentioned by Waqar in detail, that the junction of the transfer process and the lateral mass, the junction of the transfer process and the par interarticularis, and similarly in the cervical spine, the junction of the lateral mass and the entry, and the trajectory and the angle, different type of angle, that orthogonal angle must be identified and must be practiced before doing anything. As far as the cervical spine is concerned, the cervical spine confirm better fixation. These particular screw confer better fixation if you compare it with the lateral mass screw fixations. The entry point for the cervical spine is the cranial margin of the lamina for the C2, and as well as a lateral to the center of the articular mass, and just medial to the lateral border of the superior articular process for C3 to C7 entry point. And the most commonly entry point for the cervical spine, especially we use the pedicular screw in C2 and C7 only. The rest of the cervical spine, that is C3, C4, C5, C6, is better with the, and it is relatively easy to put the transpedicular screw at the level of C2 and C7, because the vertebral artery is actually situated a bit lateral as compared to these other. And the most common technique for the cervical spine, which is used by many spine surgeons throughout the world, that is Abumi technique. And the entry point for the Abumi technique is that is a slightly lateral to the center of the lateral mass and close to the posterior margin of the superior articular process. Waqar already mentioned about the zone technique, but for the cervical spine, the commonly used technique is the Abumi technique. You see, there is a very narrow margin of error in the cervical pedicular screw fixations because of the important neurovascular structure posterior, especially the vertebral artery, nerve root, and spinal cord. Therefore, while putting a transpedicular screw in the cervical spine, a meticulous planning of the surgical surgery is very crucial. The main risk associated, as already Waqar also mentioned, is the injury to the visceral, vascular, and neurological structure, and all these things can be minimized with sufficient analysis of the preoperative imaging. And the most important preoperative imaging is for putting a cervical screw in the cervical spine is the CT scan. And for a CT scan, the most important thing is one should know the direction of the pedicle, the width of the pedicle, and should be familiar at the same time is how much is the normal size of a pedicle, and and what are the size of the different type of, what is the diameter of the different type of screws and their length. The surgeon should know the must be master and must be able to read the CT scan and to identify all these important points. And at the same time, he should also know the available length, width, and dia of the different type of screw. Of course, the surgeon expertise and knowledge of the local anatomy is also important. And you see these screw then provide very reproducible result for this way. Now you see, in conclusion, I will say is that there is freehand technique for cervical, thoracic, and lumbar and sacral spine is very important. And you see, all these screw uh, give a very good purchase if you compare it with the other technique, because it hold all the three column of the spine, that is posterior column, middle column, and interior column, and very stable fixation give. This technique, this freehand technique is more versatile and more acceptable and more enjoyable in the lumbar spine, followed by the thoracic spine, and lastly in the cervical spine also. Thank you very much.
Thank you very much, sir, for your valuable opinion. So as far as for the first question regarding the format of the presentation, yes, we have designed this format. I will share my screen and show you the reference journal. So the format is according to what was published in British Journal of Hospital Medicine, October 2013. They have actually written an article on how to prepare for and present at a journal club. I have shared this article along with our template on your email. We will be really happy and pleased to know your feedback. And of course, we want to improve this activity and this template. So any feedback from the faculty and is very valuable to us. So if you kindly go through this article and our template, then probably you can give us a better feedback on how we can further improve it and what are your reservations. Dr. Waqar, if you would like to reply a few of the queries that were put in by Professor Yasab.
Okay, thank you, Dr. Aisha. First of all, I have read through this template of presenting a journal club, and it was a very it is a first experience that how to present the journal club in this format. So it need a time to practice it like that. Once we started presenting in this format, then it will be easy for in the same format, but this is the beginning for us so that's why it was a little bit difficult to put it in the exactly that format. And second thing is that I also discussed with Faiz Ali Shah. So he told me that, okay, be simple and just present your article, and it will add almost we will discuss 50% of format. So the important is that if anyone go through this format, there are most of the time it is the input from the listener also. So what they want to listen, and they have to criticize the presentation, and even they have to criticize this article. What are the deficiency in this research, and what we can improve. So this was important. And second thing about the method of freehand technique, Professor Ayaz Seb has very nicely explained in detail. And also, it is although this is a psychomotor skill of our training, so this does not this needs to be practiced on the sawbone in the workshop, and then on the patient, real patient. So it will be mastered with time. Those who are interested in the spine surgery, this is for the resident that they have to concentrate on, first of all, the anatomy. As the Dr. Professor Ayaz said, has clearly mentioned that without anatomy, we cannot do anything in this surgery. So the first thing is that you have to be mastered in the anatomy, the landmarks, the safety zones, and then you have to practice a psychomotor skill with the sawbone. the workshops on the spine surgery are regularly attended or arranged before this pandemic. But hopefully we will see in the future that we will start it again under supervision of our senior professors of spine surgeon. And uh, I have no more things.
थैंक यू आयशा। आयशा द क्वेश्चन मैंने जब वकार से, एक्चुअली ये क्वेश्चन मैंने वकार से नहीं पूछा था, ये मैंने फाइज अली शाह से पूछा था। मेरा ख्याल था कि फाइज अली शाह एंड वकार आर वर्किंग इन द सेम यूनिट, एंड फाइज ने इसको बहुत अच्छे तरीके से गाइड किया होगा कि ये देखो ये प्रेजेंटेशन आपने इस फॉर्मेट पे इसी तरीके से बनाना है। इसलिए मैंने क्वेश्चन पूछ लिया।
थैंक यू सर।
because definitely we need to improve it. और अभी
I would like to add, Aisha.
जी sir.
First of all, thank you. Today is a special day for me. Special day for me in the sense that Professor Ayaz, a renowned orthopedic surgeon who is authority on spine, is here, and he's also my mentor. That's first. And second is Wakar. We are working in the same unit, so it's actually the same. The paper is presenting from my own unit. So actually, I told Wakar to just be simple, follow that format. Okay, thanks, Professor Ayaz. We will make it more better next time, actually. And for the beginner, as Wakar has said, it's a little bit difficult to incorporate all the things which is written in that article. And secondly, spine, I would say, is rather in fancy and LRH. And we would need support of Professor Ayaz to boost, to guide our spine unit. We have Dr. Wakar, Dr. Shams, Dr. Naeem. They are doing spine, but it's in fancy, and they will need, and we will need their guidance. So the purpose is just for the trainees that they learn not only the technique but the presentation skill as well. Thank you. Now I think Aisha's few questions the audience.
जी डॉक्टर फैज, एक क्वेश्चन है डॉक्टर बादल खान है, उन्होंने पूछा है हाउ टू मेजर स्क्रू साइज इन फ्री हैंड टेक्निक।
Should I just Wakar?
जी सर कोई भी।
Okay. How to measure free hand technique? You see, the free hand, with a free hand technique, the screw measurement is very easy. Just put the ball tip feeler and sound into the pedicle, and your screw should not cross the 2/3, not more than 2/3 of your body wall. It should involve the posterior 2/3 of the body, and the screw should not reach to the interior 1/3 of the body wall. Just put your ball tip probe into the pedicle and pull it out and measure your screw length. The screw which is most commonly used in the lumbar spine is 6.5 mm screw. In the thoracic spine is 6 mm screw, and in the cervical spine, the most commonly pedicle screw is 2.5 and 3.5 mm screw. And the dia of these screw is 2.2, 2.5, and 3.5 mm for the cervical spine. The length, you can put any sort of length, but the general guideline is it should not cross the interior 1/3 of the body wall.
So I have a question from Dr. Wakar for his study. Did you measure exactly how much was the screw malpositioning for the different pathologies that you had categorized? Like how many malpositioning occurred in trauma or degenerative, or the third category was deformity? You have to unmute yourself.
Okay. Actually, this was a blind technique. So you see that the reviewer of the screw malposition or the correct position, the reviewer was the two other surgeons. and they were not aware of whether it was from the trauma or from the degenerative spine disease. So that's why this article is lacking this point, that we haven't mentioned exactly in which cases they are more common. But in the journal, you see that in the trauma, it will be very less likely that you put a screw in the malposition area. The more the degenerative process or the deformity has more chances of screw malposition, and as the doctor also mentioned. So that's why we haven't concentrated on exactly, because we have blinded this procedure, so we couldn't assess that which is.
So, have you included pediatric patients, the scoliosis patients in your study, or they were all adults?
Actually, we see that the pedicle screw fixation for a deformity correction all are more than 10 years of age. So, haven't put the pedicle screws in the pediatric.
Okay. Okay. So,
Aisha,
yes, sir.
I have a question from Vakar also. You see, majority of these screw were put for the traumatic disorder. And we all know from general orthopedic and even from the spine surgery that traumatic injury are more common in male as compared to female. But Vakar, in your study, these traumatic cases were more in female. Spine trauma cases, thoracolumbar trauma were in your study were more in female, as if you compare it with the male in your study. Is there any specific reason that why these traumatic cases were more in female in your study, if you compare it with the general population or with the general trend that traumatic, and especially in our culture and our setup, where female are most of the time they are inside the house and they are less exposed to the traumatic problem as compared to male?
Actually, Dr. Asab, this is not appreciating the whether it was from trauma. We cannot answer this question that all were the cause was the trauma, and the more are the female. In my study, we did most of this deformity surgery because you know that we put a 10 or 12 screw at least in the deformity correction. So the majority were a female patient. So that's why in the statistical analysis, the results were like this, that the female were more than the male.
Okay, so we have a question from Dr. Kashif Jan. So if we can unmute himself and ask directly. Dr. Kashif Jan. अगर तो वो जी वो आ गए, आप kindly unmute yourself and ask the question directly.
Dr. Kashif, you can speak now. Please unmute your mic.
Sir, Assalamu alaikum. How to measure the malpositioning of the screw either from medial side or lateral side of the pedicle? I mean that it is either from the spinal canal or from the lateral surface of the pedicle. Malposition of the screw.
Okay, you have seen that, maybe you have joined late, but this is assessed by CT scan axial cut, and both whether medial or lateral, they are malpositioned. The important is that in the medial breach, we have a chance of spinal cord injury and or nerve root injury, while in the lateral breach, although we have no maybe less chance of these were injuries, but mechanically that screws are a little bit weak. So you can see the either medial or lateral. The classification based on the CT scan is same for both.
Okay, so you also mentioned, Dr. Bakar, in your index case that there was some neurological issue, and you came to know it in the first post-operative day. So how come this is, do you guys not routinely monitor it during the surgery, like using neuromonitoring systems?
Actually, this was a spondylolisthesis and a single level surgery, L3-4 level, and we plan for only posterolateral fusion and decompression. So, in the routinely for these cases, we haven't used the neuromonitor. And that's why if you see the X-ray, I have shown to you that on the lateral view, it's look okay. But on the axial view, it was a questionable on one side. And we have to correlate it with clinical presentation. The patient had, if you do a surgery of laminectomy and decompression and fixation, the patient should not have any radiculopathy pain, or it should be minimized from the previous. But when we visit the patient on the next day, the patient has severe pain on the right side. So it was not bearable pain. So we were in doubt that our screw may be in malposition. So we did the CT scan for that, and the axial cut, as I have shown to you, that it confirmed that our right two screw both were in breaching the medial cortex. And on per-op revision surgery, we confirmed with a ball tip that it had breached the cortex. So we revised that two screws and just changed the direction of the screw. So after that, the patient will recover from the pain.
So generally, you would, what will you give as a general message for spine surgery? Like if some institution is trying to establish spine surfaces, is it mandatory to have a neuromonitoring service with it? Because usually that is considered one of the biggest hurdles into establishing this particular area in a department.
Definitely, because in this new era, we have medical legal cases or medical, and later on, if the patient has some issues with the surgery, and we got some comorbidity like in the form of paralysis or any nerve root injury, so the patient also suffer, and then if he is intelligent enough, the doctor will also suffer. So we have to keep safe.
आयशा आई कैन आयशा ये तो हमारी एक वो है कि हम यही चाहते हैं कि हर जगह पे न्यूरो मॉनिटर हो, हर बंदा न्यूरो मॉनिटर के लिए दौड़ता है, लेकिन ऑनेस्टली स्पीकिंग आई हैव न्यूरो मॉनिटर इन माय यूनिट और इसकी कीमत तकरीबन 1.5 करोड़ रुपए पे लिया हुआ है, लेकिन बिलीव मी कि न्यूरो मॉनिटर की यूज जो है ना वो बहुत कम होती है. In very few cases you actually need you feel a need for a neuromonitor. Otherwise rest of the spine surgery में हम routinely neuromonitor use नहीं करते हैं, ना हम neuromonitor use करते हैं, neuromonitor के use होने की जरूरत होती है, क्योंकि जब आप neuromonitor use करते हैं तो उसके साथ आपका बहुत ज्यादा टाइम जो है ना वो टाइम कंज्यूमिंग है, उसके प्रिपरेशन, उसके लिए एक्सपर्ट चाहिए होता है जो उसको रीड कर सके, वो एक्सपर्ट रीड कर. तो ये तो हमारी वो है कि यार आपके पास न्यूरो मॉनिटर नहीं है, ये कौन सी बात है. रेस्ट इफ आप रियल प्रैक्टिस में सोच लें तो बहुत ही कम केसेस है, बहुत ही कम केसेस है जिसमें एक्चुअली न्यूरो मॉनिटर की जरूरत होती है. और वो कम केसेस जो है ना वो स्पेशली वो सीवियर डिफॉर्मिटी के केसेस होते हैं जो जिसमें आप फील करते हैं कि यार इस चीज में मुझे न्यूरो मॉनिटर चाहिए होता है.
जी बिल्कुल सर, क्योंकि ये हमारा एक्चुअली अनफॉर्चुनेटली हमारे जो मेजर पीडियाट्रिक ऑर्थोपेडिक सेंटर्स हैं पंजाब में, आई विल टॉक अबाउट पंजाब, लाइक इन लाहौर, फैसलाबाद, या मुल्तान जो चिल्ड्रंस हॉस्पिटल है वहाँ पे वी हैवंट स्टार्टेड स्पाइन सर्जरी. सो जो पीडियाट्रिक स्पाइन डिफॉर्मिटी है दैट इज अ ह्यूज पार्ट ऑफ पीडियाट्रिक ऑर्थोपेडिक्स. So that's being neglected. Lekin it is also equally good that these children they go to actual good spine centers जहाँ पे spine surgeons उनको बेहतर तौर पे deal कर सकते हैं. लेकिन उसमें एक बड़ा hurdle यही है कि जो है government वो procure नहीं कर पाती ये neuro monitoring system. और दूसरी बात ये है कि सर अगर वो सिस्टम आ भी जाए तो जैसे आपने कहा कि we need experts to read the whole thing, जो system monitoring हम कर रहे होते हैं वो भी नहीं हो पाती. So if we have any further questions, the attendees can post, or they can also raise their hand and we can ask our esteemed panelists. Dr. Faiz, आप कुछ concluding remarks कहना चाहेंगे?
Well, thank you. It was a really informative and interesting session. I'm really thankful to Professor Ayaz, who has spared precious time from his busy schedule, and Dr. Wakar, and of course, Dr. Aisha. Thank you. Inshallah, we will continue and we will follow guidelines, feedbacks from seniors like Professor Ayaz, from our participant, make it more better and more informative. Thank you.
Aisha,
जी सर,
can I have one comments?
जी सर,
Yes.
प्लीज आप लोग इस तरह कर दे, दिस इज स्पेशली फॉर यू एंड फॉर फाइज अली शाह. आप जो आर्टिकल प्रेजेंट करता है उसको भी थोड़ा गाइड किया करे, जो पार्टिसिपेंट होते हैं उसको भी थोड़ा गाइड किया करे, और जो एक्सपर्ट होता है उसको भी थोड़ा सा गाइड किया करे. आपके गाइडनेस से जो है ना इसकी वर्थ जो है ना, इसकी वर्थ, ये जर्नल क्लब की वर्थ और उसकी स्टेटस जो है ना वो थोड़ा सा ऊपर जाएगा. लाइक मैं आप सिंपल सी एक चीज में कह दूं, अगर आप हमें ये कह दे कि यार आपने किस तरह रूम में बैठना है फॉर अ प्रेजेंटेशन, ऑनलाइन प्रेजेंटेशन, ठीक है, आपने कीप एंड क्वाइट रूम में बैठना है, लाइट आपके सामने होना चाहिए, कंप्यूटर आपके शोल्डर लेवल पे होना चाहिए, आप इस तरह उसमें नजर आना चाहिए. तो ये देखो, जब स्क्रीन पे नजर आएंगे तो हम बड़े अच्छे और खूबसूरत नजर आएंगे. इससे हमारी जनरल क्लब की प्रेजेंटेशन, ये ट्रूली स्पीकिंग, ये छोटी छोटी चीजें होती है जिससे चीजों की वैल्यू बहुत बढ़ जाती है. और वही छोटी छोटी चीजें अगर आप इग्नोर कर देना तो आपकी बड़ी चीज की वैल्यू जो है ना वो काफी कम हो जाती है. तो मैं आप दोनों तो काफी ज्यादा एकेडमिक्स है, फैज अली शाह और आप, तो मैं आपको यही सजेस्ट करूंगा कि आप हमें गाइड किया करें, मुझे भी गाइड किया करें कि यार सर आप इस एक्सपर्ट आ रहे हैं, आपने इस तरह ड्रेस पहना है, आपने इसी तरह अच्छे खामोश सी कमरे में बैठना है, लाइट अपने सामने रखनी है, सर कंप्यूटर आपके साथ होना चाहिए, आप मोबाइल से ना हो, ये वो इसी तरह वकार को आपने ये करना कि यार आपने ये फॉर्मेट फॉलो करना है, आपने इसी तरह जो है ना वो स्क्रीन अपना शेयर, ये सारी चीजें. इसी तरह पार्टिसिपेंट को भी साथ साथ कुछ इंस्ट्रक्शन, बिकॉज यू सी दिस इज अ कंटिन्यूअस प्रोसेस एंड वी विल कीप दिस जर्नल क्लब कंटिन्यू for the rest of the you see it is only activity only once in a month, और एक पूरा महीना हम इसके लिए तैयारी करेंगे. तो इसमें आप लोगों की इनपुट हम भी इंशाल्लाह वी विल रेडी टू हेल्प यू आउट, एंड हमारी इंशाल्लाह हमारी उस पे जो हमारी रिस्पांसिबिलिटी हो, वी विल बी ऑल द सीनियर फैकल्टी एंड द जूनियर फैकल्टी विल हेल्प यू to upgrade this journal club system, but main responsibility fall on you and Dr. Faiz Ali Shah shoulder. So please guide us, please guide the presenter, please guide the expert, and please guide the participant too. Thank you.
Thank you very much, sir. So you're very right. We should not overlook even the minor things because they create a big impact. So I agree with you 200%, and inshallah we will devise few guidelines, and I will communicate with you so that we can improve it further. So it's been really useful today. So if we have any concluding remarks from Dr. Wakar, who was presenting also today.
Thank you very much for arranging all this presentation. It was my first experience with you. Although I'm used to the online education system, but with the Journal of Orthopedic Pakistan Orthopedic Association, this was the first experience. So hopefully we will continue with this format, and it will improve with the passage of time, and it will improve with the attendees also. At the moment, there are 14 attendees, and first is my that we should also show the faces of the attendees on this slide, because we are only into a panelist. So we at least we know all our colleagues and our juniors who are attending. So we will remember who are regular in.
Remember them more.
Yeah.
So actually the viewership is perhaps more than what is being seen here, because this is also being shared on Facebook Live, and then we also put the recording on the YouTube channel. So certainly people usually listen to this Journal Club at their convenient time.
Aisha,
जी
प्रेसिडेंट साहब भी है, ईद मोहम्मद
जी
साहब भी है,
बिल्कुल सर,
अगर
प्रेसिडेंट
कुछ
साहब
कहना
से
चाहे तो
मैं
उसको
पूछने
चांस
लगी।
दे दे प्लीज.
जी जी बिल्कुल जी. डॉक्टर ईद, अस्सलाम वालेकुम, वेलकम टू.
Thank you, Dr. Ayaz, for giving me a chance. Madam, this is very healthy activity. I'm very proud of you. You people are keeping it regularly. Dr. Wakar has presented well. Congratulations to him and his mentor. अच्छा, एक रिक्वेस्ट मैंने पहले भी की थी डॉक्टर फाइज से कि अगर ये डे जो है ना थोड़ा रोटेट करते जाएं तो हर कोई इससे इस्तेफादा कर सकेगा। अच्छा, ये दिन जो हमारा है ये हमारा ओटी डे है, तो हम ज्यादा सेक्रीफाइस नहीं कर सकते। हमने सारी मीटिंग्स आपकी अटेंड कर ली है, आइंदा के लिए फिर थोड़ा सा सोचना पड़ेगा। थोड़ा आप रोटेट करते जाएं तो सब लोग इससे इस्तेफादा कर सकते हैं। मतलब कभी फ्राइडे को कर लें, कभी वेडनेसडे को कर लें, कभी उसको संडे के अलावा कोई भी दिन आप रख लें, तो मेरे ख्याल में सब लोग रेगुलरली अटेंड करते रहेंगे। तो ये रिक्वेस्ट है। वेल डन डॉक्टर अयाज, आपसे बड़ा इस्तेफादा किया। एक और रिक्वेस्ट थी, अगर एक लाइव दिखाते हैं कोई साबोन पे टेक्निक्स जो बताते हैं तो बड़ा अच्छा होगा रेजिडेंट्स के लिए। तो अगर इस तरह हो सकता है तो अच्छी बात है। थैंक यू वेरी मच।
थैंक यू वेरी मच। ये काफ़ी वैल्यूएबल सजेशन थी कि अगर हम लाइव टेक्निक्स शेयर कर सकें, उसके लिए डेफिनेटली हमें actually that will be perhaps beyond the scope of this particular journal club meeting. लेकिन जनरली जो लाइव टेक्निक्स शेयर होती हैं जैसे AO के फोरम पे होती हैं, तो उसके लिए बहुत ज़्यादा you need a very robust audio visual team that actually go there and they capture the entire thing और फिर वो telecast करते हैं. So maybe we can, in our step forward, we can start doing it, and this will definitely help and increase participation.
Thank you. Thank you.
We have Dr. Wali with us. Dr. Wali, would you like to add something?
Dr. Wali wants to answer question.
Maybe.
वो उन्होंने hand raise किया था.
I just saw it.
Okay.
उसका वो म्यूट है।
So जी वो म्यूट है और हमारा टाइम भी एक्चुअली 10 बज चुके हैं. So with this I conclude today's session and thank you very much to all the panelists and the participants for their keen participation. And this was the third virtual journal club. Inshallah, next month we will rotate the day and time to a more suitable slot and see you inshallah. So thank you very much.
Thank you very much. Thank you
Good
everyone.
afternoon.
Thank you.
Thank you very much.